Assalamu alaikum, I am Dr. Sajida. I am welcome to you in my channel PhysioEduzone. Today this video is for a special test in a hip joint. Thomas test. Aim of the test. For identities of hip flexors. Patient position. Patient is supine and one hip and knee are maximally flexed to chest and held there. Opposite limb is kept straight on table. Observe if hip flexion occurs in straight leg as opposite limb is flexed. Positive sign. Positive if straight limbs hip flexes and unable to remain flat on the table. If knee is straight indicate tightness of Hilbert's test. Aim of the test. Identifies tightness of tensor fascial latae and iliotibial bond. Patient position. Patient lies on the side with lower limb flexed at hip and knee. Passively extend and abduct testing hid with knee flexed to 90 degrees, L. Slowly lower uppermost limb and observe if it reaches the table. Positive sign. Positive if the uppermost limb is unable to come to 3. Ely test. Aim of the test. Identifies tightness of rectus femoris. Patient position. Patient prone and knee of testing limb is flexed. Observe the hip of testing limb. Positive sign. Positive if hip of the test. 4. 90 to 90 hamstring test. Aim of the test. Identifies tightness of hamstring. Patient position. Patient supine and hip and knee of testing limb is supported in 90-degree flexion. Passively extend knee of testing limb. Positive sign. Positive if the knee is unable to reach full extension. 5. Piriformis test. Aim of the test. Identifies tightness of the piriformis muscle, piriformis syndrome. Patient position. Patient is supine and foot of tested leg is placed lateral to the opposite limb's knee. Testing hip is adducted. Observe the position of testing knee related to the opposite knee. Positive sign. Positive if the testing knee is unable to pass over the resting knee and reproduction of pain in the buttock and alongside. 6. Patrick, Faber. Flexion, abduction, external rot, testing. Aim of the test. Identify dysfunction of hip and sarcoiliac joints such as mobility restriction. Patient position. Patient lies supine, passively flex, abduct, and externally rotate tested leg so that foot is resting above the opposite knee. Slowly testing leg down towards the table surface. Positive sign. Positive test when the involved knee is unable to assume a relaxed position and reproduction of 7. Standing flexion test. Aim of the test. Identify dysfunction of the sacroiliac joint. Patient position. Patient stands with his feet apart. Therapist stands behind him with his thumbs placing on PSIS. Ask the patient to flex forward as much as he can. Therapist observe both PSIS normally both equally move. Positive sign. Positive when one PSIS move further cranially than the other, which is the 8. Standing flexion test. Aim of the test. Identify dysfunction of the sarcoiliac joint. Patient position. Patient is sitting with arms across the chest. Therapist stands behind him with his thumbs placing on PSIS. Ask the patient to flex forward and pass his elbows between the knees as if to touch the floor. Positive sign. Positive when on PSIS move further cranially than the other, which affected side. The opposite is for posterior innominate rotation. 10. Trendelenburg's sign. Aim of the rest. Identifies weakness of gluteus medius or unstable hip. Patient position. Patient standing and asked to stand on one leg. Flex the opposite knee. Observe the pelvis on the stance leg. Positive sign. Positive when a contralateral pelvis drops when lower limb support is removed. 11. Leg length test. Aim of the test. Identifies true leg length discrepancy. Patient position. Patient supine and pelvis is balanced aligned with lower limbs and trunk. Measure distance from ASIS to medial malleolus on each limb several times for consistency and compare result. Positive sign. A difference in lengths between two limb is noted. Identify a true leg length discrepancy. This test will determine if the limb discrepancy is true on functional. True discrepancy is caused by anatomical difference in bone lengths, either Functional discrepancies are not anatomical in origin and are the result of company due to abnormal position or posture such as pronation of a foot or pelvic obliquity.